There is much data and research and published material to support this. The evidence is available at the highest level. I'm going to show you in a moment some histology, and there will only be one histological slide, I promise, showing the conversion of that grafted bone to vital bone with encapsulated non-converted particles. But as is appropriate, and as I'm always very proud to acknowledge, I must acknowledge my teachers and my mentors over the years. I had the privilege of training at the University of Connecticut in the 1970s. And for those in the periodontal community, you will be familiar with the names of Harold Lowe and Paul Robertson and Ken Corman and Mark Petters and Clarence Trammell, and the list goes on and on. Those were all my teachers and mentors that I'm so grateful for. And in the orthodontic community, our mentors were Charlie Burstone and Ravi Nanda and Lou Norton, and of course the Wilco brothers, who changed the way I practiced dentistry, Vince Kokich, who's influenced everybody, and Ward Smalley, and such like. Before I show you evidence, one day I was reflecting on life, as we all tend to do, and I said to myself, what is a periodontist and what in essence do we do? And so, and I'm saying this tongue-in-cheek, this is my business card, which you're welcome to call me or email me at any time. And then I really started thinking about what do we, the periodontists, do. And all we do are procedures to maintain the alveolar bone base. We are alveolar bone mongers. We try to build foundations that will last, and we try to guarantee them to be termite-free. And in essence, that is what Orthodontics does for us. We also deal in new and used bone, and we deal in human bone and bovine bone. But in essence, our job is to minimize bacterial contamination and to have a decent alveolar bony housing. And if you look at these images that I've obtained from skeletal material, Jan Lindy shows us and teaches us that ideally we need 1.5 to 2 millimeters width of alveolar bone around a tooth, and that's what you see in the upper left and the upper right image, in order to keep the tooth healthy, minimize recession, minimize resorption, and such like. And if you look on this skeletal specimen, you see the periphery of each socket is well covered by a nice wall of facial alveolar bone. And again, we are alveolar bone mongers, building foundations that last termite-free. So if we look, and I'm going to show you one histological section that I obtained from one of my patients. This was that bone that was grafted over the corticotomy on the facial surface at 9 months. I re-entered the area to place a dental implant on a patient and harvested the small segment of bone, which was sent for histological section. The dark amorphous sections are part of the bio-os particle that is still to be incorporated and converted. Notice there are no macrophages anywhere. We've got numerous osteoclasts, osteocytes, osteoblasts, and we've got very happy growing bone there. The other image that I would like to share with you, and this was the image that got me going on the PAO track many years ago. This image was in the Wilco brochure that I mentioned right at the beginning, and I've got it by courtesy of Wilco's. This is not my work, this is their work. Notice this 3D scan, CAT scan of a patient. Notice the above significant deficit of facial bone around those teeth. Notice on the other hand in the lower image the substantial facial bone around each tooth, and the Wilcos, who are absolutely to be commended for their work and their ongoing dedication and their tireless research and documentation, show us these type of images with this facial bone now I believe it's 12 to 14 years later. So this bone prevails, the morphology of the gingiva prevails, and as a consequence of this new bone, stability is enhanced because this new bone enhances the new memory associated with the tooth positions. This next series of images, also by courtesy of Tom Wilco, is a sagittal slice between the mandibular incisors. On the pre-treatment, you will notice a distance almost apical to the incisor tooth of 9.5 millimeters. 2 years post-treatment, the same patient, same site, 14 millimeters. And now 14 years later, same patient, same site, 14 years. So indeed, this bone is organized, it's vital, it's physiologic, and it is happy. The other risk that is decreased with PAOO is the risk of root resorption. I have got an ongoing in-house study at my office looking at root resorption on consecutive patients who have been treated with 4 bicuspid extractions. 4 bicuspid extractions typically require substantial tooth movement, and although root resorption is uncommon in the post-orthodontic treatment, I'm convinced, and I've developed data to substantiate it, it is much more common in the 4 bicuspid extractions, and I hope to submit that data for publication in the near future. But as a consequence of elimination of the hyaline necrosis associated with the RAP phenomenon and PAOO, we see no root resorption in our patients, and thus much greater and much more favorable crown to root ratio structures. A great article on this topic is listed here by our Asian colleagues relative to hyaline necrosis and accelerated orthodontic tooth movement in their studies in the dog. Notice the other risk factor that is decreased, if not eliminated, in our PAOO patients is that of gingival recession. These are different patients. Notice the extent of the recession. And I wonder if this is truly a genetic phenomenon associated with gingival phenotype, or if it is more alveolar bone or alveolar bone deficit associated. The upper images, surely the upper left is going to support tissue much more predictably and stably than the upper right side. Food for thought, food for thought. What is the consequence of gingival recession? Well, we've been able to show very consistently and predictably on 100% of our patients that following PAO surgery, recession is mostly eliminated and most lesions are significantly improved. Studies show us that 88% of 65-year-olds and 50% of 18 to 64-year-olds have one or more sites with gingival recession. And the consequences of gingival recession are essentially twofold. Number one is the ongoing loss of periodontal attachment and eventually perhaps development of an unstable tooth. Number two, and more importantly, is the risk as we age of root surface cervical decay, many times predicated by the sensitivity of that root surface and or the inability of the patient to efficiently debride those exposed root surfaces. So gingival recession is not a good thing. It seems to be progressive with time, and if we can avoid it in our orthodontic endeavors, as we certainly try to avoid it in our routine patient populations, indeed we should, and we should try to treat to the best of our ability. Just a short note on recession: when we do our conventional mucogingival therapies, we usually prepare the root surface by scraping away the so-called decalcified or contaminated cementum. Is that a function of decay? Is that a function of decalcification? Is that the initial material that our toothbrushes and toothpastes abrade, leading to class 5 non-carious cervical lesions? Are we accelerating that phenomenon in our patients through orthodontic therapy, where there is a thin facial bone plate that could be treated through PAOO? The next point to make relative to this program and presentation is the value of 3D imaging. I do believe that within the next generation of practicing clinicians and orthodontists, particularly, the panoramic image will be obsolete and a three-dimensional image will be the standard of care. For example, if we look at this patient who demonstrates early recession, and I draw your attention to the mandibular left first bicuspid and to a lesser extent the canine at the gingival level, if we look at this patient's panoramic radiograph, everything looks terrific. However, if we look at the same patient's 3D image, notice the profile of the teeth relative to the alveolar bone, and surely this would be a great warning that if this patient was undergoing orthodontic therapy, this would be a high-risk patient relative to potential significant gingival recession and subsequent relapse, as has been demonstrated by Laura Roth out of the University of Washington, Washington in Seattle. And this is that same patient. You saw this patient in the panoramic, but look at the patient in the 3D and then look at the clinical image. Notice the superb alveolar bone around the second bicuspid, but the dehiscences associated with the first bicuspid and the canine. And I pointed out that early recession lesion. What is the risk for substantially enhancing that recession if one proceeded with orthodontic therapy without the gingival augmentation through the PAOO process? And another view of that, putting the two together, you saw the clinical image, you saw the panoramic image of this patient. Now look at the surgical image and look at the status of the first bi and canine relative to the risk of expanding that arch in orthodontic therapy. Hence the reason why this patient was referred for concomitant PAO surgery at the time of initiating orthodontics. And yet another example of a potential disaster that might occur if we did not have PAOO. Patient referred in for treatment. Notice what deficit of bone we have once we reflect flaps. It could be a disaster. The same patient CT scan. Notice in the lower right cut, for example, notice the tooth orientation and what we would miss with a panoramic, but what we see with a CT for this patient. And here is the same patient treated effectively with PAO surgery. Notice the bony facial profile of the above, where root eminences are so prominent, the same in the mandible, and then notice the 2-month new facial profile in both maxilla and mandible as a consequence of PAOO. In this patient, I provided a connective tissue gingival graft, a connective tissue gingival onlay graft prior to the PAO procedure to strengthen, to substantially enhance the quality of the gingival tissue prior to PAOO surgery. So, as we get to the end, my friends, we know from our substantial research, mostly provided by the Wilco brothers with support from Dr. Ferguson and his BU colleagues that the evidence shows us that decortication, as a consequence of decortication, tissue turnover and memory loss is substantial, the RAP. The augmentation grafting provides much greater long-term stability. I refer you to the Roth, R-O-T-H-E, paper out of the University of Washington in Seattle. Treatment outcomes improve during retention. There is better retention and settling after decortication. There tends to be much less alignment relapse and changes during retention. One is tempted almost to minimize the use of retainers. However, we do not have enough data to support that thought. So retainers and fixed retention is still provided to all of our patients because we don't know what the consequence of decreasing that retention might be. So our cases are far more stable. Again, the benefits of PAOO are minimal recession, minimal root resorption, minimal relapse, less time in appliances and therefore decay, and much, much quicker treatment. We know that relapse is reduced, as mentioned. In addition to the surgical flap procedure, indeed, we are providing a supracrestal fibrotomy as part of the flap elevation procedure. And that in its own right, we've learned from Edwards very many years ago, will minimize relapse risk. So as I summarize and finish off, the advantages of PAOO, Periodontally Accelerated Osteogenic Orthodontics, or affectionately known as Wilcodontics, include a stable or enhanced mucogingival complexes, less root resorption, less recession and therefore perhaps less NCCLs, non-carious cervical lesions or erosion lesions, which in turn, studies have shown us, leads to happier pulps and less pulpal pathology. There's less relapse, there's decreased treatment time, happier patients, happier restorative dentists, and it's a win-win-win situation for all involved in this process, particularly the patient. So, there's got to be some disadvantages, and I will list that as well. There are not many, one's really got to think about it. And the disadvantages of PAOO surgery include an additional cost if the surgery is not completed concurrently with conventional periodontal surgery. I mentioned earlier that many of these patients require mucogingival enhancements and require periodontal therapy. So the PAO becomes part of their periodontal requirement. If that is the case, then there is usually minimal additional costs because they're incurring that cost for periodontal therapy in any case. The window of opportunity at about 4 to 6 months, the RAP effect declines substantially. However, the mere process of moving teeth induces and sustains the RAP to a lesser extent. These patients need to be fastidious about orthodontic adjustments using a heavier force than typical every 2 weeks because of this window of opportunity. So we need a very compliant patient, and we need an orthodontic office that is set up to handle 2 weekly adjustments rather than the traditional 6 weekly adjustment. There needs to be excellent coordination of interdisciplinary dental care between all providers involved, the restorative dentist, the orthodontist, periodontist, and most importantly, the patient. And sometimes we need to make sure that we can meet the patient's expectations and that the patient's expectations are not unrealistic. And unfortunately, we all have been in that situation where what the patient thought they were getting and what we thought we were providing were not harmonious. This has been a very brief overview of this wonderful topic that's emerging and I do believe will become a standard of care. For more information, the Wilcos have recently published an excellent overview article that covers this material in great detail. It is listed on the screen and it's available for your review. So I thank you so much for your time and your attention. I hope you become involved in this modality of therapy. It is fun, it's exciting. For the periodontist, my colleagues, it's hard work, but it is probably the finest service and the most fun and gratifying service I provide to our patients. I'm always keen and available to talk with you. My cell phone number is listed on the screen. My email is on the screen. And I wish you luck in the process. If you're interested in the procedures, I would encourage you enthusiastically to go to the Orthodontics website and to register for a course. It changed the way I practice periodontal therapies for our patients. My orthodontist colleague told me it changed the way he looks at his patients, and it is a truly amazing modality. If you ever want a program for your study group, I am keen and energized to present that for you. Please contact me either by cell phone or at the email. Thank you so much.